A male presents with grouped painful. So grouped painful vesicular lesions in the genital area. History of multiple sexual partners is present. Irregular use of condoms history is present. Smear showed MNGC, that is multinucleated giant cells. So what is the diagnosis? What is the diagnosis? This was a question which I received from the students. So if you get to see these kind of grouped vesicular lesions or erythematous base, and that too over the genitals, and they have mentioned you that there is a sexual risk in this particular individual. So you should think of the condition which is herpes genitals, herpes genitals. So answer is going to be option B. Option B. If it were to be herpes zoster, the examiner would have mentioned that the grouped vesicular lesions were present in a segment in the right or on the left side. Okay, but because that was not given, what I feel is better answer is going to be herpes genitals. This is the next MCQ. A 27-year male came with the complaints of asymptomatic generalized papillosquamous rash over the trunk, moist, flat, gray perianal lesions, and hair loss as given below. So what is the most likely causative organism? So please see all the clues which are given in the question. And if you look at the hair, what you are able to see over the scalp, hair loss is present in a patchy manner. And I hope you do remember the differentials, very important differentials for patchy alopecia. So important one is alopecia areata, tinea capitis, trichotillomania, and secondary syphilis. So these were the 4 differentials which you should think of. Okay. So among the 4, what do you think is the diagnosis here? So please remember when they have given you asymptomatic generalized papillosquamous rash on the trunk and moist flat gray perianal lesions, which are nothing but the condyloma lata. And this patchy hair loss, which you are able to see, it is characteristically described as moth-eaten alopecia, which is classically seen in secondary syphilis. So what is the causative organism? It is Treponema pallidum. Very, very important. We have discussed this in the class also. Moth-eaten alopecia is what you need to identify in this picture. So I hope it is clear. And this is the next MCQ, straightforward we can say. If you know, you can answer, otherwise you cannot. This is a memory based. So a young male came with GI complaints with malabsorption and diarrhea. Cutaneous examination revealed itchy lesions associated with blistering. On histopathology, cryptitis and flattened villi were noted. So most likely this is a histopath from the gut. Okay. And condition improved with gluten-free diet. What is a specific antibody in this condition? So by this time, I hope you all have diagnosed this condition as dermatitis herpetiformis, which is associated with celiac disease. Okay. And please remember the specific antibody associated with dermatitis herpetiformis is tissue transglutaminase number 3. Okay, I hope you all remember in which condition we have a defect in tissue transglutaminase number 1. If you do remember that, please put the answer in the comment section. I will tell you the answer. It is ichthyosis, lamellar ichthyosis. Okay. So this is the next MCQ. A child came with malnutrition and follicular hyperkeratotic skin lesions. There was a deficiency of vitamin A and essential fatty acids. What is the most likely diagnosis? So this is, we can say, not straightforward question because image was not given, but description was given. So you should be very careful about knowing the description of this condition, which is called as phrenoderma or toad skin, where there are going to be hyperkeratotic follicular skin lesions. Very, very important to remember. And where are they going to be present? Over the elbows and over the knees. And there can be associated vitamin A deficiency and also essential fatty acid deficiency. And also recently it was observed that vitamin B complex deficiency, C and vitamin E deficiency may also be associated with phrenoderma. And this is also basics type of a question, we can say, where you need to identify the structures. And in the exam, these structures were marked as A, B, C, D. And in the options, A, sebaceous gland, B, eccrine glands, like that it was given. But here, for the purpose of simplicity, I have put the options like this. Okay. So A, sebaceous glands, if you have to mark, so this is the sebaceous gland. Okay. Eccrine gland, I hope you do remember that this is the gland which is going to open directly onto the skin surface without any association with the hair follicle. So this is the eccrine gland. And this is the erector pili muscle. And this is the apocrine glands. This is the apocrine glands. So this we can say is a concept which is repeated. Why? Because in the INICET, latest INICET, there was a question, where can we see the apocrine glands? Where can we see apocrine glands? And the answer was axilla. So somewhat, the previous year topics are going to be asked, maybe in a different avatar. Okay, but still remember that the questions are going to be from the previous year topics, not exactly the questions, but still topics are very important. And this we can say is a question from papillosquamous disorder. Very, very classical description was given, but this is not psoriasis or lichen planus. Okay, so some students might not have read this topic, but very important. 23-year-old male complains with orange hue over the body with hyperkeratotic perifollicular erythematous papules associated with scaling. And they started over the face, slowly progressed to involve the entire body. Islands of sparing noted over the body. Palmoplantar keratoderma noted. Histology showed orthokeratosis and parakeratosis. So these were all the clues mentioned in the MCQ. So this is a giveaway question if you know all these points related to pityriasis rubra pilaris. Very, very important question, where we are going to see this orange hue over the body, and the lesions are going to be having cephalocaudal spread. That is, here it is shown, it started near the face and progressed to involve the entire body, cephalocaudal spread. And you can see there are islands of sparing, that is, islands of normal skin are seen in the entire skin. You are able to see that there is erythema, but here and there you are able to see that the skin is not erythematous. Okay. And palmoplantar keratoderma is thickening of the skin over the palms and the soles. And this is a very classical histopath picture, orthokeratosis and parakeratosis, which is called as checkerboard pattern. Okay. So these are all the important clues. Next MCQ, 4-year-old boy presents with multiple patches of hair loss, which are associated with itching and scaling. His 2-year-old sister also has similar complaints. So in the previous question related to secondary syphilis, we have seen that patchy alopecia. What were the important differentials? Alopecia areata, tinea capitis, secondary syphilis, trichotillomania. Okay, so here you are able to see another differential for patchy alopecia, which is tinea capitis. Very important. How can you come to this diagnosis? First, see, children are affected. Okay, so you should think of the tinea capitis, in which we can see this kind of a patchy alopecia. And one more clue which is given is 2-year-old sister has similar complaints. So most likely this is an infectious condition which is spreading from one person to another person. So the diagnosis here is going to be tinea capitis. This is the next MCQ. A male patient with history of unprotected sexual intercourse 4 days back. So very, very short incubation period is there. So now he's coming with the complaints of painful urethral discharge. Okay, so there is dysuria and there is urethral discharge, which is frank pus. So what is the diagnosis? You should think of gonococcal urethritis. And what is the treatment for gonococcal urethritis? It is going to be cefixime 400 milligrams stat. Okay, so somehow examiner loves gonorrhea, Neisseria gonorrhea, I think. So there was another question also related to this, intracellular gram negative Okay, where are they seen? So that was another question, I think. So somehow examiner likes gonorrhea. That's why there were two questions related to this topic. And this is, I think, a very easy question in the NEET PG, we can say, from dermatology. A patient coming with vesicular oral lesions, and DIF showed this image was given. I think fishnet was not mentioned in the question. Please put your answer in the comments whether it was mentioned in the question or not. So, but you are able to see that the epidermis. So this is the epidermis where you are able to see fishnet or chicken wire pattern of immunofluorescence. You should think of the diagnosis of pemphigus vulgaris. Pemphigus vulgaris. Okay, so I hope it is a easy question in this paper. Okay, a farmer with a history of prick injury. Farmer prick injury should think of the subcutaneous mycosis. So mycetoma, chromoblastomycosis, or you should also think of sporotrichosis. Okay. So next, what is given in the question? Complaints of swelling of the foot. Sinus tracts are present. Pus discharge is present. Granules are present. So you are able to see that there are GST. Granules, sinus tracts, and tumefaction, that is swelling. Okay, so probably we are discussing about Madura foot or mycetoma, in which we can see this triad of GST. And next, what is given? Gram-positive filamentous structures were noted on microscopy. Okay, so this statement which is given here, these two buzzwords are very important for this question, for you to diagnose the condition and also identify the organism. So please remember, this kind of mycetoma-like picture can also be seen in botryoomycosis also, which is due to staphylococcus. Okay, but please remember, in botryoomycosis, which is due to Staph aureus, we are going to see gram-positive organisms, but filamentous structures are not going to be seen. Okay, because filamentous was mentioned, so the diagnosis here is going to be the mycetoma. And that too, I hope you all know that mycetoma is again of two types, eumycetoma and actinomycetoma. Eumycetoma, it is due to the fungi, where we are going to see dark granules. So eumycetoma, dark granules will be seen, whereas in actinomycetoma, we are going to see pale or white granules. So probably the examiner is asking you about the actinomycetoma. And remember, Nocardia brasiliensis is one of the causative agents for actinomycetoma. So option C is the correct answer for this question. And this, we can say, is very controversial. Many students gave me different types of recalls. So what I got from most students was an adolescent male came with complaints of lesions all over the face and back, which were predominantly comedones. Okay, I don't know whether comedones term was mentioned in the question or given in the image. Okay, you should please comment in the comment section. Okay, so it was asked what is the most effective treatment for this condition. So here we can try to rule out the options and come to a diagnosis. Okay, so because the lesions are present over face and back, okay, topical treatment might not be feasible. And because nodulocystic acne is not mentioned in the question, so systemic isotretinoin might not be a correct choice for the treatment in this condition. And if you see option A and D, routinely in clinical practice, we do use systemic doxycycline more than systemic azithromycin, which is going to act not only on the comedones, but it is also going to act on erythematous papular lesions, okay, and also pustular lesions. So, and also because this is extensive condition, so ideally systemic treatment is what is going to be preferred. So it is option A, which I feel is the correct answer for this question. There is every possibility that there may be different question or different image. So please put your views in the comment section below. Okay. And this was next MCQ. While preparing slide for histopathological examination, box-like gross appearance is seen in the scanner view. Okay. This was what students told me that the question was given. So this is the box-like appearance. And here you are able to see the histopath picture from the scanner view. So what is the condition in which we can see this picture? So this is taken from the IJDVL article. appearances in dermatopathology in dermatology. Okay, so please remember in morphia, which is limited scleroderma. Limited scleroderma, we are going to see this box shaped or squared of appearance. Okay. So basically, this is due to the marked sclerosis of the collagen throughout the reticular dermis, and it can even extend to the subcutaneous fat. So you can remember for future examinations, there may be a possibility of lichen sclerosis morphia overlap and scleredema also to show this box like or squared of appearance. Okay, very, very important. It was not asked previously. We can say this is a bouncer, googly, unnecessary question. But what we can do? Okay, so at least you might have attempted to rule out the other options and came to a diagnosis. That is, came to a answer, final answer. So like an amyloidosis, maybe the examiner might have given you polarized microscopic image, but that is not given here. So, and like an Adidas, it is going to show claw clutching ball appearance. Okay, that is not seen in this image. And like in planopilaris, ideally there should have been some pili, that is hair follicles, which are not shown in this picture. So I hope you might have ruled out the options and came with the diagnosis of morphia. Even if this is a mistake, a wrong in the actual exam, do not worry. That is fine. Okay. So this is the next MCQ. A patient presented with nodular lesions over the body, which are associated with slight anesthesia over the arm in the ulnar nerve distribution. Okay. Histopathology is as shown below. Which of the following options is true about this condition? So many students, gave different views. Some students told that a solitary lesion was given, which was having hypopigmentation and hypoanesthesia. And there was a histopath picture showing a tuberculoid granuloma. Okay, but most of the students told me this recall, okay, that there were nodular lesions and there was a slight anesthesia over the ulnar nerve distribution. So if this is the picture which is given, so you should think of the diagnosis of leprosy. First thing, okay, is leprosy. So nodular lesions, in which type of leprosy are we going to see? We are going to see it in lepromatous leprosy. Lepromatous leprosy. Okay, lepromatous leprosy. And slight anesthesia probably could be glove and stocking type of anesthesia. Okay, the glove and stocking type of anesthesia. And some students told me that the Grenz zone was clearly visible on histopathology. I'm not sure whether it is true that Grenz zone was seen or not. But if Grenz zone is seen, nodular lesions are there, glove and stocking anesthesia is there, think of lepromatous leprosy. Okay. And so in lepromatous leprosy, you need to identify what is a true statement about this. So first we can rule out this statement. So A and C are possibilities. D is not a possibility because remember erythema nodosum leprosum can also be seen in the lepromatous leprosy pole. But if ENL has to be the diagnosis, then the examiner should have mentioned some constitutional symptoms, fever, arthralgia, myalgia, new nodular lesions which are tender. So that was not given in the question. So I assume that it is not option D. Okay, so now we are left out with option A and C. So please remember in lepromatous leprosy, the cell-mediated immunity is very, very poor. So the lepromin test, which is going to identify the cell-mediated immunity, is going to be negative. So answer is going to be option number C. Okay, I hope it is clear. If you have different views, recall, please put your views in the comments below. I will see all the comments. So this is the next MCQ. A 57-year-old completed his treatment of leprosy. Okay. So 2 years later, after the completion of the treatment, he presents with punched out painless ulcer over the sole. So most likely we are thinking in the terms of trophic ulcer, which we can see due to the autonomic disturbances. So the question is, what is the next best step in the management? So please remember, restarting MDT does not make any sense because, see, the trophic ulcers can occur even without the presence of the Mycobacterium leprobacillus. Okay, so restarting MDT is not an option. Amputation is not needed. That much, aggressive treatment is not required. And also aggressive debridement with IV antibiotics is not an option because this is not due to the infection. Okay, trophic ulcer in leprosy is due to the what we can say weight bearing areas. So the uneven pressure when it is seen over certain sites, they are going to be, the skin is going to be damaged and we are going to see the trophic ulcers. So the option A is the correct answer. Ask him to bear less weight on that leg and use plaster cast. So some students told that this was there in the options. Some did not recall it. So please put whether in the comments, please put whether this plaster cast was mentioned or not. And also I will just show you some literature about this from Joplins, which is a standard textbook for leprosy. So you can see plantar ulcers in the leprosy. We can have acute ulcers where there is going to be pain, okay, or chronic ulcers, which are long standing. Chronic complicated ulcers can also be seen. Okay, so here in the picture which is mentioned in this particular MCQ, we are discussing about the chronic plantar ulcer. So giving rest, avoiding weight, and putting cast, that is what is going to be the treatment in these patients. Okay, and this is the next question, which is a integration between microbiology and dermatology. And I can see that many students told these were the options. Okay, so what is this question? First of all, hair shaft with arthroponidia is seen in the image below. You are able to see that there are, arthroponidia inside the hair shaft. Okay, so this is basically endothrix. So now probably you might have thought, Areva, this is trichophyton. So you all know trichophyton tonsils and violation, they are going to cause endothrix variety of tinea capitis. So you might have thought to mark the trichosporon, which is option A, but please remember trichosporon bigally is associated with white piedra. Okay, but it is not going to produce this arthroconidia inside the hair shaft. Okay, so most likely this is not correct. Epidermophyton, I hope you all know that it is not going to infect the hairs. Okay, so what we are left out with Candida and Microsporum. Candida, it is not going to cause a hair shaft infection. So we are left out with Microsporum, which is option B. So Microsporum, actually, I know that it causes ectothrix variety of tinea capitis, but here you are able to see the spores inside the hair shaft. So, but what we can do, other options are absolutely false. Okay, so we are left out with one better choice, which is Microsporum. But if this was instead of trichosporon, trichophyton, then option A would have been the correct answer without any